into GUTS in the virtual community. My name is Brittany Wilkerson, and I will be your host for tonight. During this event, mics will be muted, so if you have any questions or comments throughout the presentation, please drop them in the chat. You may also text us at 301-909-8135, or you can email us at the email address that you received the registration link in. So to give you some background on GUTS in the virtual community, these events are a continuation of GUTS community efforts that were previously done in person, but due to the pandemic, we had to shift to this virtual platform. And these events are hosted on the fourth Tuesday of every month. And the goal of these is to provide clinical research awareness to the community. And we also invite speakers to come and talk about their various expertise on health concerns that you may have, or their research that they conduct in health. And if you would like to learn more about GUTS, you can follow us at our GUTS community page at GUTS Community. And you may also visit our webpage, and that link will be shared in the chat. So GUTS in the virtual community, this initiative was put together by a core team of members from Howard University, Georgetown University, MedStar Health Research Institute, and the DC VA. And we also collaborate with the GUTS Participant Advisory Board, the Community Advisory Board, and Community Engagement Team. We also collaborate with MedStar Center for Health Equity Research. And at this time, I would like to introduce our moderator for tonight, who is Dr. Veronica Thomas. And she is a professor at Howard University for the Department of Human Development and Psychoeducational Studies, as well as the Director for Evaluation and Continuous Improvement for GUTS component. Dr. Thomas is also the principal investigator for the National Science Foundation, grant funded, and the Howard University Evaluation Training Institute. And her research interests include culturally response evaluations, well-being of Black families with the emphasis on women and girls' health, and the academic and socio-emotional development of youth placed at risk. So Dr. Thomas, I will hand it off to you now.
Okay, thank you, Brittany, for the introduction, and good evening to everyone. I would like to welcome you to this event and thank you for coming. And as a reminder, again, please feel free to put your comments or your questions in the chat throughout the presentation, or you could text or email them. As well as, I want you to know you will have an opportunity at the end of the presentation to provide any comments or questions. So next slide, please. So what you see in this slide is really an agenda of what we are going to talk about tonight. First of all, I'll just give an overview of who we are, who is GUTS, what is health research, and our theme tonight is don't let the past hold back the future of health. And we will talk a little bit about some of the past ethical transgressions and abuses of research with women, in particular, African-American women, more specifically. And then we'll move forward in terms of learning from history and safely moving women's health forward. And our guest speaker, Dr. Tatiana Sanses, will talk about her research, really interesting and exciting research around pelvic floor disorders and urinary incontinence in women. Next slide. So, first of all, who is GUTS? We do have this sort of funny founding name, and it's GUTS. And as you can see in the logo up on the top right, GUTS stands for the Georgetown Howard University Center for Clinical and Translational Sciences. GHUCCTS was funded in 2010, and we represent this unique partnership among 5 different institutions, that being in addition to Georgetown and Howard, that includes MedStar Health Research Institute, Oak Ridge National Lab in Tennessee, and the Washington Veterans Affairs Medical Center. We are one of 62, I would say, elite centers across the country who was funded with a clinical and translational award by the National Science Foundation. So a big part of the work that we do is not only to actually support investigators who actually design and implement research that will have a high impact on the health of our communities, but also a big part is to increase research awareness in our diverse communities. And in keeping with the name, we fondly and sometimes boldly say that it takes guts, or it takes fortitude to make a change. And that is a lot of what we're talking about tonight, really making the change in terms of transforming clinical and translational research by engaging diverse communities and identifying and facilitating discoveries that will result in improved healthcare and public health, particularly for persons from underserved communities. That is a big focus of the work of GHUCCTS. And when we talk about underserved communities, we're not just talking about persons from diverse racial and ethnic and cultural backgrounds, but also people with disabilities and older adults. Next slide, please. Next slide. So you may be asking, what is research, or what is health research in particular? What you see on the slide is a basic definition of health research, which is the process of testing new ideas and treatments to find out how to treat, diagnose, cure, and treat illness. So you may be wondering, how can you participate in health research? Next slide. There are various avenues to find out about clinical research that you can participate in. On this slide, we list 2. One is matchresearch.org, and this is a free online tool that allows you to search for studies that you may be able to volunteer. And it really is like a matchmaker, because this website brings together people who are interested in participating in research and clinical trials with researchers who are actually looking for volunteers. So if you go to the researchmatch.com website, you will see approximately 1,000 different studies that you can potentially, well, certainly the 1,000 different studies listed under the Match Research Match website, and persons of all ages and anyone living in the United States and Puerto Rico can actually register on Match. A second way that you could participate is through looking at the website. This is a GHUCCTS, local GHUCCTS created website. We partner for research, and it is a research that you can go on and find a list of studies that are actively recruiting volunteers. So you could consider local options to participate in research studies done by GHUCCTS researchers and other people in the local community. Next slide, please. So let's talk about clinical research and more educational resources that are available for community members on the GHUCCTS website. So this is the Let's Talk About Clinical Research is a website that was created by GHUCCTS for the community to provide educational information. For example, it provides a list of research terms that you may have even heard reported in the news over the last year as we deal with this pandemic. Terms such as, you may have heard in the news, they talked about maybe with the J&J vaccine that in phase 1 clinical trial, or phase 2, or phase 3, or they talk about placebos or informed consent. So this particular website, the Let's Talk About Clinical Research, help community members to understand various research team terms that may be in the news, help It provides research information that allows community members to make better personal health choices. And it also informs people who participate in research how they are protected. There are many safeguards and ethical guidelines in place now to protect volunteers that were not in place some years ago. And we'll say a little bit more about that later. So this is what you see on the screen at the bottom is the link to that website. Next slide, please. So you may ask yourself, why participate in research? I'm not going to be somebody's guinea pig that we oftentimes think about when you may be asked to or consider participating in clinical trials or research. There are, in fact, multiple benefits for participating in research. Some of the benefits may be directly beneficial for you, because while participating in clinical trials, you may have access to new treatments for existing conditions such as hypertension, cancer, or diabetes. Also, participation could help others, family members, or friends by actually participating in research that really provides hope to other people and help researchers learn how to increase the quality of life of individuals who may be suffering from certain conditions. And more broadly, it helps science. It helps future generations. It helps to improve health in the future by what we learn from your participation in community trials. Next slide, please. So we do say, don't let the past hold you back. Hold back the future of health, because yes, there have been some very tragic and terrible abuses of people of color, of women, and others who have participated in clinical trials. But we argue that to not let the past hold you back from the future of research. It is important that diverse communities participate in research, because outcomes do differ by different populations. And we need diversity in terms of gender, in terms of age, in terms of disability status for people to participate in clinical trials, because we need to know if the things that are being done and being tested and being tried out in these clinical trials, do they work as effectively for men versus women, for young people versus older people, for people who have disabilities versus those who do not, or who are on different kinds of medication, or for African Americans compared to a white population. So this is one way, if you think about it, that participating in clinical trials can help us get closer to health equity by making all types of, by looking at outcomes for all types of individuals across, various demographic spectrum. Next slide, please. So, in terms of not letting the past hold you back, clearly, as painful as it may be sometimes, we should learn about the past, learn from the past, and to ensure that those safeguards are in place. So remembering the past and how research harmed people can help us prevent from that from happening again. We should not let the errors of the past get in the way of making advances in the future. It's important for people to know that things have changed for the better. The image that you see on the right, that is an image from 1997 in the East Room of the White House, where then President Bill Clinton actually issued a formal apology for the Tuskegee study of untreated syphilis of African American men. So things are changing. There are more safeguards in place than they were in the past. Next slide. So when we think about what is research abuse is, it occurs when people who take part in research are put at risk, they are intentionally harmed, or they are treated inequitably or unfairly. And research abuse actually goes against the 3 golden rules of research. That being, you have to respect people, do no harm, and that's physical harm as well as psychological harm, and to be fair. Next slide. So just looking back a bit before the 1970s, there was really not any way to ensure that researchers follow these 3 golden rules. Many research ignored these safety guidelines, and unfortunately, many of these studies that were done that violated those safeguards and those ethical guidelines that we have in place now that weren't in place then. Many of the institutions actually approved this work, and even some of our government agencies. Next slide. So I'm just looking at my time. So just want to give you a little bit of a story that is not told as much. Many of us are familiar with the Tuskegee studies, but this is the story of James and Marion Sims, medical experiments. Wanted to just bring that to your attention because this is in line with what we're talking about tonight around research on women and research on women, gynecological related research. James Marion Sims, actually, some of you may have heard of some of the headlines that were made in 2017 when we were part of this racial reckoning that in New York City, where his statue was racist, was actually spray painted on top of it, and they were called to remove his statue. James Marion Sims is considered the father of modern surgical gynecology, but he is probably one of the most controversial figures in the history of medicine. He had his medical training. He's from South Carolina, that's my home state. He began his practice there, but he did later move to Montgomery, Alabama, to get a fresh start after 2 of his patients died. Next slide. So in terms of who was James J. Marion Sims, he was essentially a plantation doctor who built his reputation among the owners treating enslaved workers. And much of, he actually built a hospital for slaves that he bought or rented and kept on his property, as well as for plantation owners in the communities. And, while healthcare did take place on the plantation, really difficult cases, they did have to come to the hospital. And clearly, much of this was about not so much about just the care of the slave, but if the slaves could not work, they could not produce, reproduce, and they were considered useless for their master. Next slide, please. So let's see what my time. Okay, so Sims is actually credited for revolutionizing women vaginal care and surgery. He actually cared for women who had vesicovaginal fistulas, VVF, and this happened often when women had really difficult child delivery and when the vagina actually separated from the bladder, and it resulted in incontinence, continuous leaking. And our guest speaker certainly could say more about that if you have questions. The instrument that you see on the side in the image is what Dr. Sims actually developed, and his procedures and tools are still the foundation for much of the procedures that we use today. But next slide. But he actually was able to perfect it by experimenting on enslaved African women without anesthesia. And the decision to do, so he literally sliced and sutured their genitalia without any anesthesia. And anesthesia, I will say anesthesia it existed then, but it was still kind of controversial. But Sims actually had the belief that black people didn't feel as much pain as white people, so he didn't feel that bad about doing that, and that's kind of documented in his autobiography. Next slide. And so, you know, I'm gonna sort of quickly go over this. I want to make sure Dr. Sanses has her time. So the three women that he experimented on the most and that are named of the women that we know include Lucy, Antarctica, and Betsy. And Antarctica was a 17-year-old slave woman that he performed at least 30 surgeries to actually perfect his technique. Next slide. But the good thing is that there are lots of, well, the bad thing is that there are lots of examples of this, but the good thing is that we have really come a long way. Many of these abuses have been exposed, and it did prompt change. So if you could go to the next slide. You know, and much of the change actually just beginning in the 1970s, where we had the National Research Act of 1974 and the U.S. Office of Human Protection that really actually established safeguards. And now all research must be checked by institutional review boards, and every institution that have persons conducting research have institutional review boards. And next slide. So I would just say, as I'm ending up, that in any clinical trial or any research that you participate in, you have the right to informed consent, and that means that you are given all the information that's relevant to help you make a decision about whether or not you want to participate in the study. What do you have to do? How long it takes? What's going to be done with my information? So informed consent is not just about whether you can say yes, but it's also about whether you can say no, because the slave women were not able to say no. So they certainly were able to give informed consent. And last slide. So it is important for us as researchers to acknowledge what happened in the past so we don't make those mistakes again. But it is also important for us to use the information that we learn from this to feel empowered about participating in research and making a contribution, because it really is through clinical trials and research that is our best mechanism to find effective ways to treat and prevent conditions that related to women's health and many other areas of health. Next slide. So now I am happy to introduce our guest speaker, Dr. Tatiana Sanses, who will speak about an important issue related to women's health. Dr. Sanses is she is the chief of the female pelvic medicine and is chief of female pelvic medicine and reconstructive surgery at Howard University Hospital. She's a board certified urogynecologist and a specialist in female pelvic medicine. And Dr. Sanses is also the principal investigator and co-investigator of several clinical trials related to women's health and women's pelvic floor disorders. So Dr. Sanses, welcome, and we look forward to hearing what you have to share with us today.
Dr. Thomas, thank you so much for your, first of all, your first part of the presentation. And thank you for introducing me. Thank you for speaking about the history of my specialty with Dr. Sims. So Dr. Sims, if he were alive today, he would have been called Urogynecologist. And urogynecology has certainly gone tremendous ways forward since those days. We've developed into a new field, which is now not just gynecology name, as you can see, gynecologic surgery. It is a urogynecology, which is the specialty that specifically focuses on surgeries that are related to bladder in women. And fistulas, or vesicovaginal fistulas, is the condition that I frequently take care of. today. Fortunately, it's not as often as it used to be. And fistulas are actually one of the oldest in history pelvic floor disorders. It's even been documented in wives of Egyptian pharaohs, 5000 BC, and it's been documented in the mummies. So it is one of the oldest pelvic floor disorders known to human history. Not only we've delineated this specialty as a part of gynecologic surgery, but we also now emphasize that urogynecology is not only about surgery, but a lot of things that what you do is medicine. So that's how it evolved further, and it received a new terminology. In 2013, it became a board-certified specialty, female pelvic medicine and reconstructive surgery. So we treat our women with medicine first, and only if they do not do well with medicines, and then we resort to reconstructive surgeries. And I'm very excited to be here and talk on my personal perspective of where we are today, so it doesn't hold us, that the past doesn't hold us back, and we learn from the past, and we move women's health and women's health research. You can't move women's health research without pushing forward women's health research. So I'm really very grateful to GHUCCTS community and the GHUCCTS leadership for supporting this event, and also supporting specifically my research that I do for women. Next slide. So in the theme, to continue with Dr. Thomas, we're going to learn from history, and I'm going to just show you a few examples of how we safely perform, how we safely move women's health forward. And the punchline, the theme of the talk is really those who don't know history are destined to repeat the mistakes, repeated. Next slide. So we're going to focus on women's health, and as you can imagine, women's health is very basic. It's any particular treatment or diagnosis is a branch of medicine that specifically focuses on well-being of specifically women. This is what I do for a living every day, and I love doing it. And I'm doing this since 1996, when I graduated from my medical school. Next slide, please. So part of women's health, and women's health evolved quite significantly. So now we have female pelvic medicine, which is my branch, or urogynecology. We also have gynecologic oncology. These are the doctors who specifically work with women with cancer. We have maternal fetal medicine. These are the doctors who take care of women with high-risk pregnancies. We have generalists who just do annuals and pap smears. And then we have also doctors who take care of women who are not able to get pregnant, or infertility doctors. Moving and narrowing down specifically to my specialty, these are the most common pelvic floor disorders, and vesicovaginal fistulas and rectovaginal fistulas would be not the most common, fortunately, condition. But most common pelvic floor disorder is urinary incontinence, bowel dysfunction or fecal incontinence, any problems with the bladder where you're not able to urinate, pelvic pain, any problems with sex, and I frequently also see women with urinary tract infections. Next slide. So when I see women with pelvic floor disorders, women frequently come to me without knowing much about it, and frequently I get asked a question: how common pelvic floor disorders? And the pelvic floor disorders are extremely common, as you can see on this slide. And the first two bars on the left are just showing how common pelvic, in the blue, these are the numbers. So we estimate that about 25 million women in America have at least one pelvic floor disorder. And this number, if you can see from the blue bar to the red bar, you can see that the number is expected to increase significantly by 250. And it's mostly because the population in the world, and specifically in the United States, is expected to continue to age, and the population 65 and older is expanding more rapidly compared to younger population bracket, and pelvic floor disorders tend to develop more as women get older. So the number of women with pelvic floor disorders will continue to increase. So, and one of the most common pelvic floor disorders is urinary incontinence, followed by problems holding stool. Very embarrassing condition, could absolutely ruin your quality of life. And then prolapse, which is not the topic of the day, but it's also something very commonly that we even perform surgeries for. Next slide. Pelvic floor disorders are unique in terms of many women have it, 1 in 3, but not a lot of women talk about this because it's really a private issue. Women are not willing to speak about this condition or conditions just freely, even with their friends or their family members. So this example, and I'm not a big fan of Dr. Oz, so I'm not supporting Dr. Oz, but he did speak about one of pelvic floor disorders, and he did acknowledge in his talk that this is the slide, suffering in silence. And frequently that is the case, that women come to me, to my clinic, and they were not able to speak with even their previous physicians. And they're the first, they're talking to me about their condition for the first time. And I have no idea what Dr. Oz has in these little glass jars. But next slide, please. And this is again to just emphasize that pelvic floor disorders are not frequently reported and underreported. And this is specifically the study about urinary incontinence, where 62% of people, and it's actually not specifically to women, just in general, men and women never really discussed this condition with their providers. Now, why is this usually underreported? So frequently, girlfriends would frequently talk about, their treatment for breast cancer or how they had a heart attack, and et cetera, et cetera. But women will not share that they need to wear pads. It's just embarrassing. They're afraid to talk about this because they're afraid of social stigma or consequences. A lot of women don't believe that anything could be done, or we had some surgeries that potentially not had the best outcomes. So a lot of women are afraid to even have treatment or surgery because they're concerned that this could make things worse. And there are some women who believe that urinary incontinence or not able to hold your bladder is just part of being getting older and aging, and thus they don't do anything about it. But what happens as women get older and they become more socially isolated, because now they don't want to go outside, so they become more and more confined to their whatever the environment is, which eventually leads to worse depression and worse cognitive function. And eventually, this can actually even lead to nursing home admission. And urinary incontinence has been cited as one of the leading causes for nursing home placement, which can be quite devastating for family and for a woman patient. Next slide, please. So speaking again about pelvic floor disorders or urinary incontinence, it's not specifically limited to older women, although the prevalence of pelvic floor disorders and urinary incontinence does run more frequently in older population. But roughly, I would say that any audience that I speak, I would say, whether it's young or old, I can say 25–30% of women at least experienced some episode of some pelvic floor disorder in their lifetime. Next slide, please. So this is just an example of another condition. It's a urinary incontinence type, which is most commonly encountered in middle-aged women. You can see women exercising here, but I see a lot of women in my clinic that are not able to exercise because they have leakages with coughing, laughing, and sneezing. And we can do a lot of things. We actually have great surgery for this as well. But we do observation. I have a special, I call it bladder boot camp clinic or pelvic floor therapy clinic where women get one-to-one physical exercises practicing. Pessaries, which is a little rubber circle that can also support the bladder, and eventually surgery. And women actually do really well with some of our surgical treatments. Next slide, please. So we spoke a little bit about urogynecology, about the history of urogynecology, especially with experiences that Dr. Thomas described with care that was provided by Dr. Sims, who is considered to be still a father of gynecology. And when I was a medical student, he is still in every textbook of surgical gynecology. But this is not what we do today. And women's health research is very different from those days. And I really love this circle. I would put a woman instead of star in the middle of it, because it's really the circle where we ask a question that is clinical. So if I have a patient that came to me to discuss her condition and whether it's to prevent, diagnose, or treat the condition, if she poses a question that I'm not able to answer in a straightforward fashion to her, that becomes a research question. And then we develop the research question, and if we're lucky enough to complete the research and answer the question, then this goes into the next stage, which is evidence summary. We learn from the research. And then once we obtain enough evidence about this particular question, and it's usually not just one study, it depends how great study is, but usually it's at least several studies. Then this summary becomes becomes part of the guidelines, which is now the next step is translation into guidelines. And then we also study and we do practice integration of this knowledge. And then we evaluate whether what we thought we studied is correct and truthful. So, and that's your stage 5, and that's a full circle. And that's what we do in our clinic. And it's just fantastic that I have this opportunity to communicate with women who come up with questions and I frequently don't know the answer. And then I start the engine and we develop this into a research. And this is how we move forward women's health into, to provide better care to our women. Next slide, please. So, and this is a specific study that we are currently conducting at Howard. It is suspended because of the COVID. I made a decision to suspend the study because my age group population of women is 65 and older. So I was very concerned. And I actually suspended the study 2 weeks before university shut down research operations, and actually before it became really bad. We are looking into resuming currently the protocol with a modified schedule with a lot of Zoom exercises. But the study originated exactly in the same circle from previous slide, where I had a patient who inspired me to dedicate my academic career to helping women with urinary incontinence. And if you remember from previous slide, urinary incontinence is the most common pelvic floor disorder, and currently we estimate that 18 million women suffer from urinary incontinence. So as I say, when I'm in the clinic, I help one patient, one woman at a time. When I'm doing this research, and if it's helpful, then this will go into guidelines, and eventually this will be helping 1 million women at a time. Next slide, please. Belmont report, which actually was developed here in not far away from Baltimore, Maryland. So the 3 golden rules of research: respect for persons, beneficence, which is do not do harm, and fairness or justice. These are all principles that all research that is currently performed in the United States and actually around the world follows these 3 golden rules. And this is, of course, something that we do here at Howard as well. And it's not only specific to women's health, but we certainly guard this in women's health very seriously in a very strict fashion. All women undergo informed consent. We specifically delineate all potential benefits and risks to the patient. And we always care. We want to make sure that the treatment that we provide is fair and just to the participant. Next slide. So again, learning from previous lessons from history, we developed regulations, and we follow the federal regulations, which are focused on protecting our participants, making sure we're informing participants, and we obviously do research review before we even start, just to make sure that and I don't do this. I come up with a research question, and somebody else reviews this to make sure that this is safe and fair for our patients. Next slide, please. I'm sorry, I think my computer is about to shut down, so let me just make sure I connect to the energy source. Okay. So just as an example, every study, every research trial that is conducted at Howard undergoes a specific board review. It's called Institutional Review Board, and it's done multiple cycles through the year. We provide the reports of the progress. The study usually is approved. Well, you have to submit the continuation every year. So there's a lot of paperwork that is that goes into place, and it's all really to follow these 3 rules that we discussed about, which is informed consent, do not harm, and be just to all participants. So it's a very rigorous process. Next slide, please. So in summary, as we started with our theme, that those who don't know the history are destined to repeat the mistakes, but we also would like to add that those who don't know the history and who don't implement the rules to prevent it from happening again are likely to repeat the history. So we definitely implemented a lot of rules on a federal level and university level to make sure that women's health is moved forward safely. Next slide, please. And this is just an example, and I really, really miss the time, pre-COVID time. As you can see, no one's wearing masks, and everyone is super, super happy and enthusiastic. This is part of my team for this exercise study that we're doing for older women with urinary incontinence. And I'm indebted to all my team members that I wouldn't be able to do this by myself, and especially I won't be able to do this without women who come and volunteer their time, and it's quite rigorous to participate in the research. Next slide. All right, and I look forward to any questions, and I think I've seen some questions, but I just needed to finish my talk so I can focus on any questions. So sorry if I didn't ignore any questions. And thank you everyone so much.
Thank you, Dr. Sanses. and certainly we welcome persons actually communicating their questions in real time. But I do see a question here. I can't tell who it's from, but the question is, do you see there being research done for women under 55 with urinary incontinence? I know many women who have this issue with no explanation.
So first of all, I see patients in the clinic, and I see as my clinic, I see the age population from 0 to 99. The youngest patient that I've operated for prolapse and incontinence was 20 something, and the oldest woman in my practice that I operated was 94. So specifically for the study, wise, I plan to expand research to middle-aged women as well, but at the present time, the way study is designed, if you're interested to participate, is 65 and older. But you're always welcome to come and speak with me in the clinic. And I'm happy to also for women, the other women, just to explain and talk about the condition. Again, just because it's underreported, women embarrassed. So I'm happy to talk to anyone in my clinic as well.
Okay, I have a question. If you could just talk a little bit more what happens in your bladder boot camp.
Okay, this is, yes, bladder boot camp. It's a very popular topic. So you probably all heard about Kegel exercises, right? So, and you probably all right now, if you're thinking about your bladder, you probably start squeezing your pelvic area as you're sitting and trying to kind of squeeze the vagina, okay? Kegel exercises were actually described by Dr. Kegel in 1941. He was first one to describe pelvic floor muscle weakness and potentially what could be done about this. The caveat to pelvic floor exercises is that because it's a hidden muscle, and if I tell women, well, just go and do Kegel exercises, there's actually six out of 10 women will not do it correctly, believe it or not. So it's a really, really big number of women that really need to have individualized program. So that's where I call it a personal bladder boot camp. We meet with women, we identify women who are able to do this on their own, and then we just guide them. Women who are not able to do this on their own, then we have our own tricks. We have some things to wake up their muscles. I have a pelvic floor physical therapist who works individually with each person. And as a first-line treatment for urinary incontinence, pelvic floor physical therapy is recommended by all our society guidelines to be as a first-line treatment, and which is why I have my FAME trial that is even more. It's a next step of bladder boot camp, because I'm actually taking the research further, not just as focus on pelvic floor exercises. I want to take this research further outside of the pelvis. So kind of think about outside the box or outside the pelvis. The control of pelvic floor muscles, whether you're able to squeeze it or not, really depends on how well you're able to coordinate your body overall. So this is why the FAME itself study is just pelvic floor physical therapy in one arm and pelvic floor physical therapy with general exercise in another arm. And that's an experimental arm, because I do believe that women who get bladder boot camp with generalized exercise program actually will do better. And we've identified the population for older women, because I just believe that older women are sort of in a dire need for this. That doesn't mean that younger women don't need this, but I had to start somewhere and just build from there. So that's how we ended up with a population 65 and older.
Oh, okay.
Mhm.
Thank you. I see we have a question from Dr. Carla Williams, who is asking, does treatment for colorectal cancer, surgery, and radiation increase risk for pelvic floor disorders?
Absolutely, absolutely. We actually published, one of my residents, we published a report on prevalence of pelvic floor disorders in, it was a gynecologic oncology patients, but a lot of the treatments are similar, which is radical surgery with a lot of nerve damage and radiation and chemotherapy. Chemotherapy does not affect pelvic floor as much, but surgery and radiation could be absolutely devastating. And it certainly does make things worse. And so we don't have a GYN oncologist here, but we frequently would do a combined surgeries for patients when I was taking care of women with cancer. Yeah, great question.
Okay, other questions from the audience? Well, while people are thinking, could you share, are there other, I mean, risk factors you've talked about, certainly related to surgery and cancer, but other sort of demographic risk factors, age being one, is obesity a risk factor, or are there other risk factors that women need to know about?
Yeah. So pelvic floor disorders are unique in terms of it's not just one reason why you develop this. So for, in the simple example, if you have a bladder infection or sometimes you call it UTI, it's just a bacteria and it's sitting and causing problems in the bladder. With pelvic floor disorders, because it's a multifactorial etiology, we divide the risk factors kind of in 4 categories. And there are some predisposing factors, which could be genetics, could be some collagen tissue. You might be unlucky. Your mom and dad had given you what we call a stretchy tissue, or sometimes you can have there's a condition, it's Ehlers-Danlos syndrome, where a person has like a hyper flexibility of joints and can do like really cool things. But the reason they can do that is just because their collagen or their joints or their connective tissue is just super stretchy. So, and obviously if that weight goes into the stretchy area, which in this case for women, vaginal opening is kind of like a natural weakness, then these women become a naturally predisposed to pelvic floor conditions, and whether it's urinary incontinence or prolapse, that would be a predisposing factor. Now, then there's a triggering factor, and the big trigger, there is a giant elephant in the room, which no one can basically avoid unless you have a C-section, so vaginal deliveries. Vaginal deliveries are considered to be a major triggering event for pelvic floor disorders. And the research is out there that 3 deliveries are really bad for you, 3 vaginal deliveries. After that, it's kind of already just bad. But from 0 to 3, the risk of pelvic floor disorders increases in linear fashion. So these are triggering events. Hysterectomy, for example, also could be considered a triggering event. And then there's other, from what we call promoting factors. And promoting factors, that's what you, Dr. Thomas already mentioned, the obesity, chronic cough is really bad. So women who have COPD and they cough constantly, this is really bad for your pelvic floor. Obesity, we already mentioned, and I'm just going to give you an example. So just losing 10 pounds, if somebody is obese, improves your symptoms of urinary incontinence by 30% just from get-go. So really significant risk factor. Constipation is a really bad, factor for pelvic floor disorders, because again, there's a constant pressure in the pelvic area. And then finally, after these promoting factors as a woman goes through the lifespan. So we've had this predisposing, triggering, promoting, and then finally what we call decompensating factors. So in menopause is a natural decompensating factor for developing pelvic floor disorders. So, and that's, and because it is a multifactorial condition, and, you know, some things we can't really prevent. If you have to, women going to continue having vaginal deliveries, and C-sections actually don't even prevent pelvic floor disorders 100% anyway. So there's lots of opportunities for women to get to know about their health and do something about this. So even if they develop a condition, or for example, like urinary incontinence, that it really stays under control, that you know, doesn't put you in a nursing home at the end of your life.
Thank you. Are there any other questions or comments from the audience? You can certainly unmute yourself and ask any question or make a comment that you might have. Well, let me ask a question. Do you, I mean, because as you started out talking about this, and we even, you know, even from the sort of looking at history, how this is a condition that for many women, it's a source of embarrassment, a source of shame. Like you said, they don't tell anybody, you know, they suffer in silence for a long time until they must disclose or see a healthcare professional. Do you see that changing any? I mean, you said you've been practicing since the 90s. Do you think attitudes are changing? Because you do see on TV now that they advertise for you know, pads for urinary incontinence that are a little more jazzy than you know, than they were before, and actually they have younger women. You know, the women in the commercials are middle-aged women. They're not you know, they're not much older women. So I'm just wondering, have you seen attitudes around this issue change over the years that you've been practicing?
Oh, absolutely, absolutely. And women are now more open about things. There's also a lot of patient communities that specifically dedicated to pelvic floor conditions or surgeries. So, you know, with social media, things are a lot more accessible from you talk to women one-to-one. We had, so our society has a community for patients. It's called Voices. It's pelvic floor voices or something like that. So women, again, have the opportunity to even contact providers or find the provider. In fact, actually, I'm working with one of the patient community program. It's called Pelvic Floor Awareness Program, where I'm hoping to develop some talks specifically tailored to our population, because as I discovered, our women are not talking about it as much as I would say in a normal, you know, in a normal community. I think our women are still underserved. They don't really know about that the care is available for example, for bladder. They continue to suffer silently until somebody either sends them to me, or they finally, it's just so bad that they have like 5 things going on, and then finally they actually come in. So I hope to continue improving this as things develop. But you know, we're definitely in the right direction. There's no question about it. And the specialty, our specialty is still pretty young. If you consider we're board certified, you know, since 2013, it's less than 10 years ago. And the Urogynecologist Society was also formed like about, you know, 30, 35 years ago. So it's still really young specialty, very invested into women's health, understanding pelvic floor disorders as it affects so many women. So there's definitely more research is going to come out, and women are definitely more open to talk about this.
Thank you. Any questions, comments? You can certainly feel free to unmute yourself and speak up.
Thank you, Dr. Thomas, for wonderful, wonderful questions.
Thank you. I actually have more, but I want to give our audience an opportunity to ask questions they may have. Okay. So back over to you, Brittany, I think.
Yes. All right, well, I would like to thank everyone for joining, and thank you so much, Dr. Thomas and Dr. Sanses, for your presentations and for providing so much, wonderful information for us. And if anyone would like to learn more about participating in clinical research, you can visit our frequently asked questions page, and this link will be shared in the chat. And you can definitely find more information about clinical trials and just commonly asked questions about participating in research. And we would also like to share a link for you to complete a post-survey event. We definitely appreciate your feedback. We will also be sending this survey out in an email right after this event. And it'll just be a few questions that we would like you to answer so that we can improve future events. And let's see. And within a week, we also will be sending out a recording of this event to the individuals that registered for this. So you can be on the lookout for that. And our next event will be on May 25th at 6 p.m. And this topic will be on preeclampsia and pregnancy complications and how research can help moms and babies stay safe. So we hope to see you at our next event. And if you have any questions, please send us an email. And thank you again for joining.
Thank you, Brittany, so much for hosting this. I really, really appreciate the support of GHUCCTS. It's just really fantastic that we have this wonderful community.
Yes, and thank you.
Yes, thank you, Dr. Sanses, and everyone. I certainly learned a lot, and this is good information to share with people in the community.
Mm-hmm.